The poor prognostic factors include age, male, obesity, hypertension, and diabetes. When you look at the inflammation, there are several reports indicating a severe inflammatory storm through cytokines, particularly IL-1, 6, and 8, tumor necrosis factor alpha, interferons, and so on. And you see on this diagram, the IL-6 in the people who died was much, much higher than the survivors. Now, what has been happening? Well, one important issue was brought to our attention by Henry from Ischemic Acta recently, is the dysregulation of the renin-angiotensin-aldosterone system that leads to the severe inflammation, causing lung injury and hypoxemia. So inflammation together with rash, hypoxemia, and direct infection of the endothelial cells promote a hypercoagulable state, resulting in thrombosis that causes multi-system organ failure. So, what's happening in COVID coagulopathy? Well, I think the major offender that affects any possible part of the body, and particularly the organs, is endothelial dysfunction that promotes coagulation and also decreases fibrinolysis. There is evidence that the angiotensin II induces tissue factor and PI1 expression by endothelial cells, and there is a PI1 TPA imbalance, basically leading to hypercoagulable state. It may explain also why fibrin deposits are seen in the alveoli in ARDS patients. Angiotensin II also stimulates release from adipocytes and may in part account for the increased severity observed in those with high BMI. Also, there is suspected increased aldosterone state based on hypokalemia. We also know that aldosterone levels correlate with PI1 levels, and aldosterone directly increases PI1 expression, especially in renal tissue. Now, coming to this, we can see the effects on the large vessels, and we have high prevalence of DVT, high prevalence of pulmonary embolism, and stroke that Kimon talked earlier, and visceral arteries and peripheral artery embolization. But currently, based on anecdotal reports and publications, the embolization in the brain, visceral and peripheral arteries is much lower when compared to the VTE events. Next. Now, here's one of our patients that presented with phlegmesia. The leg was very painful and swollen, so immediately you have to go and remove the thrombus. And you see the thrombus is occupying the entire lower extremity. And this is what we've seen in our center and in other places. Thrombosis is apparent within the 24 hours of admission, with increasing cumulative frequency over time. Next one. Now, what happens now in the coagulation? Well, there's clear increase on the D-dimer on the fibrin degradation products. About 15% of people have decreased their platelets, but they have increased platelet activity. The fibrinogen is interesting because in the beginning, together with the IL-6, they increase, but as the time goes by, the people go to the what we call low-grade DAC and a decreased fibrinogen and microhemorrhage. And the PTA and PTT activity, it might be somewhat prolonged and it varies with time, but usually the thrombin activity stays within normal limits. A pool analysis of 4 studies having 553 patients demonstrated that the dimer value was markedly higher in patients with severe COVID compared to those without. Now, it's interesting talking about D-dimer and coagulation. Heparin, it looks to be a key molecule because being a natural anticoagulant, had anti-inflammatory properties, being also antivirals, competing with the virus for positions on the receptors and offers somewhat endothelial protection. As a matter of fact, low molecular weight heparin has been proposed particularly for COVID due to high anti-inflammatory option that's proven in multiple publications in the past, particularly when we're treating people with cancer. And here I'd like to share with you some data from our own institution, which is, we just basically finished writing the manuscript. As you see, the D-dimer level in people being on standard anticoagulation protocol, they've reduced mortality, and also the D-dimer levels remain low, compared to the people off protocol, where they're having a much higher mortality and the D-dimer levels are sustained. Now, how can we relate COVID-19 coagulopathy and stroke? Well, clearly, there is a large VTE frequency. It is possible that there is paradoxical embolism, right? As the emboli travel from the legs to the lung, can also, in certain patients, with a right to left heart communication, send some emboli in the brain. However, we have no reports on this yet. Emboli from the heart are likely to happen, but few reports in a very small number of cases. Another area is the carotid arteries, the aortic arteries and branches, which clearly inflammation of this kind could probably trigger inflammatory components within the plaque, increase hemorrhage, and potentially cause rupture. But this is a hypothesis, we don't have data on this. And within the brain, thrombophilia, and particularly in a recent report, it was shown that lupus anticoagulant being increased in the transient form, and there might be some association. But within the brain is probably the least incidence among the causes I referred to you. But for all of the above, there is low or no evidence to support it.
Nico, just a question to interject. I see you're talking about carotids. What have you seen in your institution? Do people, for symptomatic carotid disease, do people go ahead and do them now, or do they postpone them, anticoagulate and postpone in terms of stroke?
Majority of the cases, we anticoagulate and postpone.
Yeah.
There have been two cases where we did, because I think, as you know, in symptomatic carotid, the largest benefit is within the first 14 days, and ideally within the first week. So if a patient is symptomatic and is ipsilateral to the carotid stenosis, and the stenosis is more than 70% on everybody, or more than 50% in males, it's best to operate as soon as you can.
Yeah, yeah.
And we've done that in occasion, but we offer to the patients. It's actually also patient's decision. The patients sometimes don't want to.
Yeah, yeah. We're seeing on our end, we're trying to postpone as much as possible, but you know, most patients don't want to have anything done.
To interject, Kim, on here in the discussion, in your own institutions, in how many carotids have you operated recently on COVID?
0. They've all been postponed. There have been 11 cases that have all been postponed. Nobody wants to have an intervention.
Alex, what's your experience?
I'd say we've had few symptomatic carotids, but no interventions.
Oh, same like everybody then.
Yeah. We're trying to postpone. I mean, I saw actually a recent forum that's kind of international people, and they were recommending dual antiplatelet therapy, high dose statin, and postpone the case to when there's better ability to discriminate between COVID and non-COVID.
All right. So
sorry for the interruption. Yeah, here.
So other things you have to consider, though, since we're talking about stroke, but the CNS altogether, right? A lot of people, like about 25% of them, that CNS manifestations such as headache, dizziness, confusion, but 0.5 to 5% stroke rate, with an average value around 2.5%, like Kim showed. Ataxia about 0.5%, and seizures about 0.5%. But these data come from retrospective, low evidence studies. There's only one prospective study having only 41 patients. And none of these studies appropriately looked at CNS manifestations. This is a recent systematic review paper on the Journal of Neurological Sciences that addresses some of the above. Now, What else can we assume to put the CNS manifestations, a stroke, and what happens to the patients after the discharge? Well, microvessel thrombosis and cerebral vein thrombosis. For cerebral vein thrombosis, there is evidence in one report for about of an incidence of 0.5%. And I know of some anecdotal reports myself. However, until now, we have no brain autopsy data yet, but it may occur as it occurs in other organs, like the lungs primarily, the kidneys, and the intestine. We have very good, elegant autopsy reports on microvessel thrombosis in these organs. So therefore, it could happen on the brain. And brain hemorrhage in anticoagulated patients, and as I said in the previous paper, there is only a 0.5% incidence, but definitely we have anecdotal reports, a couple in our own center, one for sure, a few in Mass General Hospital, and a few that my colleagues, they're gonna talk a bit later. Next one. Now, after discharge, actually, a lot of people may have what we call impaired cognitive function and reduced ability to focus. I mean, personally, I have colleagues, friends of mine, that 2 weeks after COVID in the intensive therapy unit, that reduced ability to focus. That's amazing. But therefore, we need to study this phenomena, look at the incidence, severity, and duration, because as I said earlier, none of this has been studied appropriately. And I'm saying this in the context of coagulopathy and stroke, because sometimes you get a large vessel occlusion that they give you the definite impact of stroke, but sometimes you may have what we call micro thrombosis, like in other organs, that may explain the symptoms of the manifestations of the CNS that we just discussed now. And I think that's all I had to tell you. I don't want to bore you with too many details. I hope you get the idea why COVID has such strong coagulopathy force. I think here, Kimon, go ahead.
Yeah, thank you, Nikos. No, I mean it's very telling that as you were saying earlier when we were offline, this is a disease that affects the endothelium, and as such it affects every organ, and the interaction of the endothelium with the bloodstream obviously has to do a lot with thrombosis and everything else, and you're giving a very nice outline of how things are going. So far we've presented kind of a more 30,000 feet view that we're really not seeing a stroke epidemic together with a COVID-19 epidemic, and certainly let's see.
Actually, I have can I ask a question to Nikos?
Oh, yes. Before that, just give me one quick second. Sorry, I got distracted because I think it's Juan Acosta from St. Catherine's. Hey, Juan. He's asking a question. Could the impaired cognitive function have anything to do with hypoxia? Do we have any evidence of that, Nikos?
I think it's very likely, at least the initial stages. But after the people being discharged, they have very good saturation, so they don't really have that much of hypoxia, unless it is in a micro level within the brain. That's a possibility.
Okay. And so the prevalent hypothesis, I guess, is that it's microthrombosis and some sort of similar to kind of a global cognitive dysfunction, right? The cause of
it will be common, but we need some brain autopsy studies to go there. But you see, if you take the loss of smell, taste, the confusion, the dizziness, the ataxia, all this together lead to some kind of generalized attack on the brain tissue from microthrombi. But
yeah, gotcha.
I would say seeing is believing. We got to some autopsies.
Yeah. Javad?
Nikos, I just wanted to ask, in your studies, have you followed up these patients with their fibrinogen levels and their D-dimer levels and seen a correlation, or even if you've done TEG at all to see if there's a correlation, if you increase the dosage of heparin, these levels also start decreasing the D-dimers and the fibrinogen after a couple of days, or try different prophylactic doses on these patients?
Yeah, I didn't go through our full protocol and stuff. Basically, what we've done in our hospital, relatively soon. If the patient has a D-dimer of less than 1,000, we give enoxaparin of 40 milligrams daily. If the D-dimer is more than 1,000, but less than 3,000, we give enoxaparin 40 milligrams twice daily. And if the D-dimer is more than 3,000, we give enoxaparin 1 milligram per kilogram twice a day, or therapeutic anticoagulation with intravenous heparin. On this protocol, actually the observations, they are correct. The D-dimer does go down. Not on everybody, but on the majority of the cases. And it matters if you start early, because if you start late, you don't have an impact actually. It's too late to do anything about the regulation at the late stage.
Yeah, and then we have another question/observation by AJ Berdia from St. Charles, a good friend and a neurologist. He's saying that he's noting psychiatric issues in patients discharged with COVID-19 and in a delayed fashion. I don't know if you guys have similar experiences. I see Alex is shaking her head. Are you seeing that?
Yeah, it's hard to know whether it seems a little out of proportion to the usual delirium that we see in patients. Obviously, these are patients who have been very heavily sedated and even paralyzed for a while. But it does seem like there's very delayed awakening and then confusion, paranoia,
Yes.
and what seem like delirium symptoms, but I don't know if it's just due to the sedation or whether there's a secondary neurological event happening as well.
Gotcha. All righty. Let's see. Excellent. So now we will try to transition again. You know, we've spoken a little bit about the epidemiology, about the fact that COVID-19 and stroke result in more death. And Nikos has given us a very good insight into the pathophysiology of thrombosis in this disease. Now we're going to go a little bit more on the practical side and talk about treatment of stroke in COVID-19 patients with our two clinical experts, Dr. Ahmad and Dr. Reynolds. They will focus a little bit on their experience on the ICU side and how to treat these folks. And we're going to start with Dr. Ahmad, and we're going to do this experiment of sharing the screen again. So let's see if we can do it. Third time's a charm, Jabal.
Someone else is sharing the screen currently, so maybe
I'm gonna stop. Here you go. Stop sharing.
There you go. That's good.
Good.
You got it up?
We got it up.
All right, great. Good afternoon, everybody. My name is Dr. Ahmad. I'm the co-director of the Neuro ICU at Good Samaritan Hospital. Like Kimon was explaining earlier, I'll be speaking about the management of stroke patients, of COVID-19 patients with strokes. Quick disclosures, no disclosures to report. Quick outline overview. We'll be speaking first of a quick overview of incidence of strokes at CHSLI, like Dr. Beckles explained earlier. We'll speak about if management differs in our COVID-19 patients with strokes. I'll present a quick vignette on one patient that we had in our neuro ICU that had a stroke and was a hemicraniectomy watch, and we can go over the vignette and introduce concepts of a safe code stroke. And we'll talk about the important question as well, very important question about starting AC post-strokes. Also, just like Nikos elaborated, also starting prophylactic AC and what doses we should start in our patient population. Again, this is a diagram that Dr. Beckler showed that there were less thrombectomies done at Good Samaritan Hospital. It's important to realize that we tell our patient population, especially our EMS colleagues, to implore the patients that they should not hesitate to call 911. We don't want concerns of COVID-19 to deter people from, or patients from, seeking medical attention at any point. Again, to spot a stroke, it's FAST, face weakness, face drooping, A for arm weakness, S for speech difficulty, and T, time to call 911. Again, can't stress enough how important this is to make sure the patients know, the public knows, and that we all act upon this accordingly. All right, so just to start our acute stroke vignette, we'll talk about a 62-year-old male. He's a right-handed male. He has a history of hypertension, high cholesterol. He was admitted into Good Samaritan Hospital secondary to COVID-19 and hypoxia. On day 2 of his admission, nurses noticed in morning rounds the patient was aphasic and plegic on right side. A code stroke was called, and the patient's NIH score was 21 at that point. I think it's important to go over relative and relevant labs. A patient was SARS-CoV-2 positive. The ferritin level was 650 at that point. The D-dimer level was 960. It was 0.96 in our labs, but 960. Like Nikos was explaining, there are cutoffs that each institution has. So, 1,000 and above may be a cutoff. So at this point, we know that the D-dimer is 960. CRP was elevated as well, as we expect since patients in an inflammatory state of 88. Most other labs were stable. His AST, ALT, alphos was a little bit elevated. Lactic acid was mildly elevated at 2.2. Platelets were 355. It's important to notice that as well, because there's been publications about patients with thrombocytopenia or decreased platelets, and maybe that being the causal reason of why there may be fewer strokes in these COVID-19 patients. But our patient had platelets of 355. These are the images. On the left, you'll see a chest X-ray image of the patient. The patient has bilateral peripheral opacities, as you can tell. Again, signifying likely the patient has COVID-19 as well, and corroborating that. On the right side, you have a CT head, an axial view of a CT head of the patient. On the left side of the brain, which is the right side of the monitor, on the left side, you see a clearly, let me see if I can use this here. Not sure if my mouse shows or not, but you can see it.
Yep.
Right. You can see a clearly well delineated stroke in the MCA region here in the patient. Again, this patient is 62 years old, and this is day 1 of the stroke. So it's already well delineated. So you would expect on CT perfusion as well, even the perfusion did not come out great, you would expect that there's also a nice mean transit time change here and a blood volume change here. Basically what that means is we do the CT perfusion to see if patient is a candidate for thrombectomy or not. Based on the fact that patient already has changes and delineation of the stroke on the CAT scan here, and changes here in the mean transit time and the blood volume, patient has a fully matched scenario. As a result, patient's not a candidate for a thrombectomy. I think we have a question here now.
Oh, yes. Let me, do we? Not that I see. Do you see a question I don't?
Okay. All right. So
Oh, yes. Oh, yes. You mean a poll? Yes, absolutely. Sorry. So yes, we wanna get your input. So on this patient, now you've seen all the data, the D-dimers, you've seen the scan, large MCA distribution. Here's our question to you: would you anticoagulate this patient or not? For not necessarily for the stroke, but for COVID, like we've been discussing. And I see the answers are coming in. And Javad, I think you can keep talking. I'm going to stop this in a second.
So we'll continue to talk. I'll actually move on to the vignette course from a system-based approach, so that we can get through the course pretty quickly. From a neurological perspective, the patient was transferred to the neuro ICU. Since patient had a pretty sizable left MCA stroke, patient was also being watched for a hemicrania watch. Basically what that entails is the patient is going to be watched as vigilant as any other patient would be, even if they're COVID positive or not COVID positive. That means patient will be receiving Q1 neuro checks. Patient's head of the bed would be 30 degrees, neck would be midline, sodium goals would be greater than 140, and serial CTs and neurological exams were again performed until we were, as a team, happy with or content with the fact that the patient would not swell to the point where patient would need a hemicraniectomy, or if he would need a hemicraniectomy, we would probably pursue that sooner than later. So I'm just receiving the poll here. Would you anticoagulate this patient? Yes at 69% and no 31%.
So we'll keep going, and we'll tell you what we did. I'm gonna launch another poll about the agent in a second. So what kind of agent would you use? Since I see the majority of you would anticoagulate. Keep going, Javad. Sorry.
All right, sounds good. So patient was closely watched. Again, this is an important considerations during this time, and it's very important to know that if the patient, as you can tell from respiratory-wise, patient required 4 to 6 liters of oxygen. Overall, is quite stable, saturating well. The PF ratio was also above 200, 250 on the 4 to 6 liters. Okay, got the pull here as well. So important considerations were if patient decompensated from a respiratory point of view, would we be able to prone the patient? Knowing that the patient is a hemicranie watch at this point, if we do prone the patient, there will be an increased chance of increased cerebral venous pressure, an increased chance of intracranial pressure. As a result, worsening cerebral edema and possibly a herniation event. So these were considerations only if there were if it was a necessity. At that point, it was not a necessity, so therefore we didn't have to actually think about it and go further. And from another consideration, which we'll be talking about later on as well, is, and Nikos also addressed, the DVT chemical prophylaxis on patients like this. Would we do it? Would we say start Lovenox on this patient? Would we do it daily versus BID dosing on these patients? Again, the D-dimer again was 960. Based on the logic from Nikos and based on the logic that I'll be presenting as well, starting a DVT chemical prophylaxis of Lovenox 40 milligrams Q daily sufficed. Moving forward, patient's respiratory-wise, like we said, patient was saturating well, 4 to 6 liters of oxygen in his neuro ICU stay. Cardiac.
Sorry for the interruption. Couple of things. So the one of our participants, Jay Yassin, is saying the stroke is much too large at this point to anticoagulate. So he's probably in your camp, which is a little different than the majority, I think, because I don't think you ended up anticoagulating this patient.
Yeah, I'll touch that, and we'll talk about that in a second and why.
Yeah. So we're getting this impact, and I put the poll results up if you want to take a look.
Great. So cardiac-wise, patients EKG with sinus echo. Again, this is an important point because we can do serial echoes on these patients to see the progression of if there's any pulmonary hypertension or if there's any RV strain. These patients. Patient had mild LVH, ejection fraction was 60%. And pulmonary pressures were within normal limits. Now, this is what we were talking about. AC was not started on this patient. We'll speak more about it as the case ensues. Okay, renal-wise, patient was stable. So this patient did not develop any of the AKI that you've seen in a lot of these sick COVID-19 patients. Patient was given Lasix PRN to have a negative balance to euvolemia. For his eyes and nose. ID wise, this was 3 weeks ago when we didn't have much data about hydroxychloroquine. So a patient was started and completed a course of hydroxychloroquine and AZT azithromycin. Patient was also started on 7-day course of Zosyn for presumed aspiration pneumonia. Hemonc wise, patient was stable. Hemoglobin, hematocrit, and platelets were all stable. In our institution, we actually performed screen Dopplers on all of our COVID patients on day 3 and day 7 to be hypervigilant, to make sure that these patients do not require any or need any further anticoagulation, because if anything, if they were positive at these certain days, or if we had a gestalt that we had to perform these Dopplers sooner, there would be more evidence in starting, say, heparin or Lovenox full anticoagulation. Endo-wise, patient was quite stable. We placed the patient on Lantus and high SSS. DVT prophylaxis, like I explained, we started the patient on Lovenox 40 milligrams daily and Pepsid 20 milligrams BID. Resultantly, patient was transferred out of the ICU, stroke day 8. Neurologically, patient was stable. NIHS was 21. Respiratory-wise, patient was also stable, and he was set up for a PEG as well. During this time, it's just important to realize that we were doing serial CT scans as well, and we continue to be hypervigilant with our neurological checks. So now,
Javad, one thing, in terms of, so if you were to anticoagulate, and I think we'll get to a question later with Alex where she anticoagulated a patient. Looking at the choices of agents that folks voted on, what's your take on the appropriate agent to anticoagulate somebody in this? And I know there's been multiple people have been doing different things. They've been doing heparin, they've been doing Lovenox, they've been doing DOAC. Some people even have been doing TPA. Obviously not in a stroke case, that would be insane. But from these options, what do you think would be your choice in a COVID patient that's deteriorating. You think you need to anticoagulate. Nikos talked a little bit about heparin, I think, and kind of his predisposition to use it because of the benefits it has, not only as a anticoagulant, but in inflammation, antiviral, and other issues. What's your take on the options? I think obviously the audience favors heparin and Coumadin, but what's your thought?
I think that's a complex question, and this is what this slide is for, as I just am showing here. It's a very complex question. There's a lot of decision making that goes into figuring out what to start. So for this specific particular patient has a large MCA stroke. Patient is from a respiratory standpoint saturating quite well. There haven't been any reports of major DVTs, and the pathophysiology of microthrombi affecting organs, say like the kidneys, haven't affected this patient. But if patient were to have, say, pulmonary symptoms or worsening RV strain, what I would probably use, and there's many publications about which agent to use. I probably use heparin initially, as it is easily titratable and easily manageable as well, and you can reverse it quite quick as well. There's some publications about starting DOACs in a lot of these patients. The reason being is, maybe Nikos can also jump in as well. But the reason being is these patients are not only prothrombotic, but after some time they become hyperfibrinolytic. So therefore, they're kind of using everything that they have, or we're using everything that we have in our system. We're clotting and we're unclotting, and we're in overdrive. So a lot of our antithrombin 3 is used as well. So it is postulated that DOACs kind of skip that phase, and DOACs are not involved in the extrinsic pathway. As a result, it's postulated that DOACs may do well in these patients as well. But initially, if I were to choose something and a patient was decompensating in front of my eyes, I would choose heparin as well, just because it's easily titratable. And at some point, start Coumadin down the road if that was.
Javad, you're right. I mean, in this scenario, heparin would be the best thing, and it's supported by the hepatological societies, mostly because it's immediate reversibility. And in such a complex scenario you're presenting, heparin probably the best way to go.
Yeah, I mean,
let me go through a couple more questions while we're at it, just so that we don't lose track of the people, because there's a lot of them coming in. So, Karen Antaki, the stroke coordinator from Comprehensive Stroke Center at Good Samaritan Hospital, is asking, do we have any evidence? These people say you put obviously not in this case, but you put a COVID patient in anticoagulation after a stroke, and then you discharge them, right? I mean, how long are these people staying on anticoagulation? When do you stop it? Do you transition them to something? For how long are they staying on it? I'm sure there's no evidence, obviously, but what are the practices that people have on that?
Maybe Nikos, you can.
Sorry, I did not follow. I was looking at some of the comments, Kimon. I did not get your question. Sorry.
Oh, no worries. No, the one of the questions is, for how long do you anticoagulate these people? Do you stop it on discharge? Do you keep them out of the hospital?
You keep them out of the hospital, because we know now, and actually including our hospital, that people coming with DVTs and PEs after the discharge. The official recommendations we wrote through the American Venous Forum suggest for at least 30-day coverage. And in our hospital, we're going to testing it right now. We're looking with ultrasound at 30 days. If there is evidence of thrombus, then we continue. If not, then we stop.
Gotcha.
But definitely have to continue after discharge.
Mm-hmm.
Gotcha.
I agree with Nikos in that regard as well. I think a serial ultrasound should be done on these patients outpatient, and also following the patient's risk factors and the improved bleeding risk factor as well. If these patients have an improved score, which is a score that shows these bleeding risks in patients, then I would be apt to continue some of the anticoagulation for longer. So again, this is just all conjecture. But
although difficult to be done as an inpatient, as an outpatient, you use easily the Caprini score, which is a very reliable and validated score. And if you go and work by clinical measures and risk factors like Javad mentioned. So if your Caprini score is very low, you may opt to follow up the patient and do nothing. If it is like 8 or higher, then for sure you need to anticoagulate the patient.
So let me go quickly through some other comments. Sorry if I'm mispronouncing names. I really apologize. Vahid Behravan says he has 4 questions, and let's go through them quickly so that we don't get completely off time. First of all, have we compared the severity of strokes pre and post COVID-19 pandemic? In our data set that we looked at, we did not compare the severity. However, we controlled for the severity. We don't have the NIH stroke scale because this is discharge data, but we have whether the patients got thrombectomies or received TPA. And so we use the surrogate of severity. But that's a great thing to do in a prospective study, or if you have the real data to see if you're getting more serious or less severe strokes. The next question is, any difference in efficacy of IV TPA in COVID-19 patients versus non-COVID? Real or theoretical? Any thoughts on that from Javad or Alex? Maybe you've seen any differences?
I've only used TPA in the context of massive PEs, not in patients with strokes at this point. So gotcha. I don't really have a comment.
Gotcha. So, I mean, I don't think we have any. I mean, we've been giving TPA. There's much fewer TPAs that we're giving because there's fewer strokes, but you know, we don't have any evidence. And these are actually great questions to look at in the study matter. So thank you for pointing them out. Third question, do you see a decrease in strokes both in young and old? Absolutely. We're seeing a decrease in both age groups. And that was the graph that we showed you where both lines were going down, but not dramatically, but definitely going down and significantly down, and in the multivariable setting too.
That schema is also true for, like you said on your talk, for myocardial infarction. In our hospitals, the reduction in both stroke and MI, you know.
Absolutely. And then the question is, what medical treatment would you use also in a patient with a simultaneous large hemispheric infarction, like the case Javad showed, and bilateral PE, for example? Not an IV candidate, but you know, could have thrombectomy. So what direction would you go? You have a large PE and a large hemispheric infarction COVID patient. What direction would you guys go, Javad or Alex?
Like initially, like I said, I think I would, if I were to go that route, I would use heparin.
Yeah,
okay.
We've been doing heparin no bolus.
Even in the large hemispheric infarction, like the one that we just showed.
Well, if the PE is quite large enough and is causing the patient to be in respiratory compromise, and if you have a PF ratio in the hundreds or even less than that, and there's RV strain, especially if there's RV strain and there's issues with the heart, then you kind of, you know, you put in a place where you have to make a decision, and that's when, you know, you.
I agree. Here is the case where lung goes before brain chemotherapy. You got to do that.
Yeah,
I know it's hard for me to believe that happens ever, but I guess
if the heart's no longer beating, then the brain can't really function either. So
exactly.
Hard for me to believe. All right. Next, Maria Bastinen says, looking at the CAT scan, there seems to be a malignant infarct, the one that Javad was showing. On what day post-ictus did you start? Oh, actually, he did not start anticoagulation at all. Sorry if that was miscommunicated. He did not start AC. And I think he's agreeing with you that the risk of hemorrhagic conversion in this case is very significant. And the fact, you know, patient had an echo, there was no RV strain, and the D-dimers were not dramatic. They were elevated, but they were not dramatically elevated, as Alex is going to show in the case to follow. You know, so he didn't anticoagulate, right, Javad?
Yeah. There was no causal reason to anticoagulate at that point.
And there's another question about what agent would you use on the outpatient setting. You guys would transition mostly to Coumadin, right? When you send somebody, COVID-19 patient, home on an anticoagulant, do most people do Coumadin, or do they do DOACs, or what do you guys do?
we've been using DOACs.
Okay.
Yeah, as an outpatient, DOACs will be fine in chemo. That's no problem. As an outpatient.
Yeah.
All right. Sorry for the interruption. That
No, absolutely.
Okay, keep going, Javad, because we have only a short amount of time, and we want to get
finish up. Yeah, absolutely. So again, we spoke about should manage stroke patients with COVID-19 change, and I think we all touched upon that. Now, this is an important graph. Actually, I wanted to present this. As Kamon was saying, now that we have a trajectory or a downslope of COVID-19 patients, we have to figure out how we're going to triage these stroke patients. And this was modified from Baroncini and colleagues in Italy. So we have a stroke patient. We either suspect that the patient's positive already, or the patient was admitted, or patient was positive in the ER at some point, or on the floor, or if there was COVID-19 and it's suspected to be COVID-19. Now, if we go down the left side of the graph, which says COVID-19 positive, we treat this patient like any stroke. So we do a cerebral CT, CTA, CTP. Again, it's imperative that we keep this we do this as quick as possible, but at the same time with the appropriate PPE. So if it's a large vessel occlusion, if there's no large vessel occlusion, the patient will be sent to a dedicated COVID-19 unit to be taken care of. If patient has a large vessel occlusion, then the patient will go to the endovascular suite. Now, general anesthesia will be the denominator to decide if patient goes to a dedicated COVID-19 unit, if patient receives local anesthesia, and if patient receives general anesthesia is intubated, secondary to the fact that patient's respiratory status is worsening or the NIHS is elevated, patient goes to an ICU area reserved for COVID-19 patients. So again, this graph is the hope of this graph is to kind of clear up any confusion going forward from now till when COVID kind of slows down. And now if patients COVID-19 suspected on the right side of the graph, it's imperative that we fast track a nasopharyngeal swab of these patients and do it as soon as possible. That is an important key step. And then afterwards, we do a cerebral CT, CTA, CTP. Again, we're in the correct PPE. If patient has a large vessel occlusion, yes or no. If patient does not have a large vessel occlusion, let me just see, I can't really see. Patient does not have a large vessel occlusion, then we send the patient to a dedicated area for COVID-19 suspicion area. Patient does, patient goes to angio suite, and then we have this middle box here, COVID-19 results. Now, if patient is negative.
So, Javad, Jay Yasin says they don't see IVTPA in the pathway. Where does that fit?
Say that again.
So in your graph, one of our
it'll be there as well. So you can also place it if patient has.
So it would be probably before.
Yeah, probably before all this, right? This is just solely talking about the point of this graph is to show where patients will go after, say, a thrombectomy and whatnot. Okay, but he's right as well. It would be before the large vessel, before large vessel occlusion as well around here. Okay.
Yeah, I think they're trying to make it not super busy, but obviously TPA is a key component of this. And so,
yeah, it's a very key component, absolutely.
And I don't think that our decision for TPA or not would be affected by the positivity for COVID, despite the fact that COVID patients we're seeing have worse outcomes when it comes to stroke.
Exactly. So to move forward, so patients go into this COVID-19 result box waiting for their COVID-19 results. If they're negative and conscious, patient is transferred to our neurostep. If they're negative but intubated for any reason, patient goes to our neuro ICU. Now, if they're positive and they're intubated, the patient goes again to the ICU for reserved for COVID-19 patients, and positive and conscious patient goes to a dedicated COVID-19 unit. So basically what this graph is showing is that we're compartmentalizing the patients that have COVID and the patients that do not have COVID for future references. All right, so that's that. And now treatment paradigm. So we've been talking for the past, been talking for the past 30 minutes, but this is basically the gestalt of our management at Good Samaritan Hospital. In our practice, full AC is given for evidence, again, of systemic thrombosis or worsening pulmonary symptoms. We give full AC if there is a reason to give full AC in these stroke patients. In the setting of segmental MCA stroke, again, like we said, anticoagulation for COVID-19 should be considered in an individual basis, like we explained earlier as well. AC for standard indications will be given based on an accepted stroke protocols, just like if patient has an atrial fibrillation event or if patient has a left ventricle thrombus as well. Then we also consider giving AC. The question is, when do we start giving the AC, sooner than later? And an important question I think that we should all address is it plausible to increase a DVT prophylactic dose in COVID-19 patients? either patients with strokes or without strokes. So even patients without strokes, is it plausible to increase the DVT prophylactic dose in COVID-19 patients? This diagram here proposes actually increasing the dosage of Lovenox or heparin based on creatinine clearance and BMI. The bottom part of the graph shows if patient's creatinine clearance is greater than 50 and the BMI is less than 30, we start Lovenox 40 milligrams sub-Q daily. If the BMI is greater than 30.
And Javad, maybe we leave that screen up as I'm gonna go to 3 more questions, and Alex is getting ready to go for her part since we're kind of maybe running low on time. And people can look at this and look at how we're doing it. But quick questions that I see from the audience. So one question by Susan is if our patients who are COVID positive and have a stroke, are they at greater risk of another stroke? Well, you know, I don't think we have a good answer. I think it's a great question, but you know, like everything, we're lacking the observational data at this point. Obviously all patients that have had a stroke, that's a risk factor for another stroke. I don't know if the addition of COVID-19 puts those folks at a higher risk. We would know that in the future when we have more perspective or actually more long follow-up on these people. And Susan had another question, why not adding hemoglobin A1C to the lab panel as patients with diabetes have a high risk of stroke. You know, we absolutely agree with that. And to kind of tag along with another question that Jane Peng is asking, you know, about risk factors for stroke, do we see them in people with stroke and COVID-19? Absolutely. You know, we did not see an increase in stroke in COVID-19 patients as was kind of the popular belief. By looking at a large number of patients, we saw that the majority of the impact on stroke incidence was actually the classic risk factors that, Jane, you're describing in your question. So we don't think there's an association at all, at least at that level. All right, sorry, Javad, if you want to.
I just want to finish up if you don't mind. Yeah.
So
yeah, everyone's read this diagram. Again, this is just a very rudimentary diagram. It's important to look at the right side of the diagram. Also, we believe that consider this diagram for low bleeding risk factors, like we talked about. Improve score, bleed less than score 7 or lower. If patients improve scores less than 7, you'll be off to kind of start patient on Lovenox 40 milligrams twice a day as well. Also want to consider D-dimers like Nikos was talking about. Say if the D-dimer is greater than 1,000 as well, you have more reason to start BID dosage of Lovenox as opposed to Q daily dosage. And there may also be some predictive value in following fibrinogen levels, IL-6 levels, AT3 levels, and even doing TEGs or performing TEGs in these patients. Again, this is all for debate, but there may be some validation in performing these further blood tests. And again, it's also up to the clinician to consider surveillance Dopplers, bedside ultrasounds, and echocardiograms as deemed necessary. So that's really it. I don't know. Are there any questions in regards to that? Come on.
So there's 2 last questions. Maybe Alex, you can commandeer the screen and start sharing yours as we're answering this last question. It's from Vahid Behravan, and the 2 questions are, 1, in anticipation of having full anticoagulation, with COVID patients, did you set up any criteria on which post-IV TPA patients could go to step down or the floor? So did we have any thoughts, any changes in IV TPA? If you know, kind of disposition wise, did we have? I don't think we had any specific criteria because
we didn't have specific criteria just because I don't think we had a stroke patient that received IV TPA with COVID-19. But my gestalt would that patient would still come to the dedicated COVID unit if they are COVID positive, and again, it will be a stroke neurologist or the neuro ICU team following that patient.
Gotcha. And then the other question I think probably for me is if we saw a change in the ratio of young and old stroke patients post-COVID. Question is, did you have more older or more younger, or didn't change compared to the pre-COVID? No, the ratios were very similar. You know, we did not do a statistical analysis all on it, but the ratios unadjusted were almost identical. All right, Alex, take it home.
All right. So I'm just going to mainly talk about some medical issues in neurocritical care of the COVID-19 patients. And then I'm going to quickly talk about intracerebral hemorrhage as well, but I'll try to go fast because I know my time's pretty much up. I have no disclosures. So first we'll talk about ischemic stroke issues and then just a little bit about hemorrhagic stroke. So I thought I would present a case. We've actually had several cases that were very similar to this, but this kind of highlights very nicely the medical comorbidities that occur with COVID-19 infection. So we had a 39-year-old man with hypertension and hyperlipidemia. He presented out of the window for TPA, which is how we've seen most of our stroke patients present, actually, unfortunately. His fiance said that she couldn't convince him to come to the ER because he was nervous about getting COVID-19. And it was only once he became poorly responsive that she was able to bring him in. So 5 hours after his last known well, he initially presented to an outside hospital, and there they found a right P1 occlusion. He had a favorable CTP, and so he was transferred for thrombectomy to our institution. He had a TICI-2B result, and post-thrombectomy, his stroke scale decreased from a 16 to a 10, with most of the points actually improvement in his responsiveness. As part of our protocol, we have been swabbing every patient who goes for any type of neurosurgical procedure, and he was found to be COVID positive. But as you can tell, based on this chest x-ray, we had a very high suspicion that he was COVID positive. Post-thrombectomy, he developed a significant acute kidney injury. His creatinine leapt up from normal at 0.7 to 2.5 in less than 12 hours. On our bedside echo, his EF looked globally depressed. He had no EKG changes that were specific, but it just looked like globally down LV function. His COVID-19 PCR was positive, so he was transferred to our COVID neuro ICU. We actually have the benefit of having 2 ICUs that our team is running. One is a general COVID ICU where we preferentially put all the COVID positive neurological patients, and the other is a COVID negative neurosciences ICU. So he came to us. Initially, he was on just a couple of liters of nasal cannula, but his respiratory status worsened. He went on BiPAP on fairly high settings and ultimately got intubated for a poor PF ratio of 159 and increased work of breathing. We were able to get an MRI. This is about 24 hours after thrombectomy. Unfortunately, it showed a near holo PCA infarct. And his D-dimer on arrival was greater than 20,000. And over the course of probably about 36 hours, he developed a high pressor requirement, and bedside echo again now demonstrated new right ventricular dilation and dysfunction. So we made the difficult decision to start on a heparin drip at this point, but I'm wondering what other people would say.
So I'm just putting that poll up there, and Alex will continue her talk, but yeah.
So we obviously could tell this was very, very high risk for hemorrhagic conversion, but this was a gentleman who is now on an epinephrine drip because of his RV dysfunction. And we did not want to give him TPA. Unfortunately, he continued to develop worsening renal function. He received large doses of furosemide, but was completely anuric. His potassium rose to over 7. He developed EKG changes. His exam worsened. It was hard to tell at this point whether it was due to his significant uremia. His creatinine bumped to 16.5. At that point, we figured there probably was a component of thrombosis of the kidneys, just because this was an extremely quick creatinine jump for an ATN. I see most of you agreed with me to do heparin, thank you. We started him on renal replacement therapy. Despite the heparin drip, we tried to keep it at a lowish goal to prevent hemorrhagic conversion. His hemodialysis catheter kept clotting. His PF ratio worsened. He was on 100% and a PEEP of 15, and we could only get his PaO2 to 84. We attempted pronation with improvement in his oxygenation, but unfortunately, on day 5 or 6, he developed an acute ischemic hepatitis. It almost looked like an acute Budd-Chiari, with severe worsening shock on triple pressors, and ultimately had a cardiac arrest and passed away. And we fought hard to try to get an autopsy on this gentleman, but as you can imagine, this fiance of this 39-year-old man, the mother of 2 of his children, just could not bring herself to subject him to an autopsy, unfortunately. So I think this case nicely outlines several issues that I'm just gonna try to quickly talk about. So Javad already talked about this a little bit in the difficulties with a hemicraniectomy watch. We've actually had, in the first 3 weeks of our COVID time, we actually had 7 patients who were on hemicraniectomy watch at Mount Sinai Hospital. This is a submitted publication. It's a little difficult to read maybe, but the main points are that we have various organ systems, including mechanical ventilation, your hemodynamics, your cardiac function, and your need for renal replacement therapy. And red is bad for all those things, green is great. And you can see there's one gentleman who's actually still hanging in there in our hospital. He actually presented with a stroke and a concurrent STEMI. And he's doing quite poorly, as you can tell, but family's not willing to transition to comfort measures. We've done 3 decompressive hemicraniectomies. One had a concurrent STEMI, unfortunately, and passed away from cardiac dysfunction. And the 2 decompressive hemicraniectomies that we've done that were successful, you can see the other organ systems were really quite minimally affected. The patients were COVID positive, but really with minimal oxygen requirements. And one was transiently on pressors for about a day and a half. But they're both doing actually quite well for patients who required a hemicraniectomy. Notably, one did develop both a DVT and a PE. That was not hemodynamically significant, but was quite large. And so we did start anticoagulation on that patient around day 11. So, what you can see is that if you're extremely sick from other complications of COVID, you're not going to do well, but we did have 2 patients with fairly good outcome as long as their organ failure was otherwise minimal. Javad touched on some of these points. What we found was that patients may actually need earlier hemicraniectomy if they're going to need it. Because of their pulmonary disease, we often have to allow permissive hypercapnia because we just cannot ventilate them appropriately. And so this causes increased swelling and earlier worsened intracranial pressure. We have been holding anticoagulation for large stroke unless absolutely necessary for hemodynamically significant PE. We've tried not to use things where the reversal agent might make them procoagulable. And then these patients are often heavily sedated if they are sick enough to require intubation, and sometimes paralyzed. And so the only real exam finding we have is their pupils. And so we have not been proning them so that we could at least have the pupils to follow. We've touched on most of these anticoagulation concerns. No one really knows the appropriate timing of anticoagulation post-stroke. We've had 1 patient who had a large stroke and a hemodynamically significant PE, and that patient was not, appropriately, I think, not considered an ECMO candidate. And of course, in order to go onto ECMO, you need large boluses of heparin as well. And so, if you're not willing to bolus heparin and put them on a drip, then they're likely not an ECMO candidate. These are our anticoagulation guidelines, which sound maybe a little bit more aggressive than Good Sam. So for any patient who's COVID positive with pulmonary infiltrates or has a D-dimer greater than 1,000 at any time during their stay, we are preferentially giving Lovenox. We're monitoring 10A levels. I will say, in general, I don't give Lovenox to patients where I am concerned for hemorrhagic transformation because I don't think that the reversal is as good. And I think that the anti-10A level takes longer to come back, and so it's a little harder to monitor these patients. Moving on to renal replacement therapy, we know that intermittent hemodialysis is associated with very large fluid shifts. And so we've been preferentially starting these patients on continuous renal replacement therapy, which unfortunately is a large burden on our nursing staff. But I think it's a safer thing to do if you're going to have a large stroke. We have found several dialysis catheters that have clotted off despite low dose heparin systemically and additional heparin in the circuit. In particular, we had one of those hemicranie patients is a large a holo MCA stroke. And he has clotted off his catheter innumerable times. And despite even being on large doses of heparin, he interestingly has not ever hemorrhagically converted. And we know that he's reopened his MCA based on bedside Dopplers.
Wow.
So it's pretty surprising that he hasn't actually hemorrhagically converted. And then, as I mentioned in this case, severe uremia can confound the neurological exam, confuse us, wonder whether a patient is seizing. And so there is a benefit to dialyzing these patients just to help us monitor them better. And then I just quickly wanted to mention what our experience has been with hemorrhagic stroke. We don't really know the true incidence in critically ill patients, I would say, because a lot of these patients are sedated, paralyzed, and will die before we can ever really get a true neuro exam. But at our institution, we found several patients, both on the floor and in the ICU, that have had intracerebral hemorrhage in the context of being anticoagulated. We've had kind of two phenotypes. This is the first phenotype, a kind of small peripheral cortical hemorrhage. This one on the left, we found presumably quite late, actually. This was a patient who was paralyzed, proned, and then was not waking up fast enough, and this was incidentally found. But then the second, more devastating type of phenotype is this one. You can tell by these hematocrit levels that these patients were all on anticoagulation. None of them were super therapeutic, interestingly enough. And unfortunately, all were so unstable that we weren't able, one actually nearly arrested in the CAT scanner. And so we haven't been able to get vessel imaging to understand whether there was an associated vascular malformation or whether this was, like a cortical vein thrombosis and a venous infarct. But I would say they don't look classically like that. They do look, to me, like what we often see with just coagulopathy related hemorrhages, but again, these were patients who all had PTTs within therapeutic limits. And so I think
folks did not have strokes, right? They were just anticoagulated for COVID and.
Correct. Yeah. So they did not come in with strokes. They were anticoagulated for their very high inflammatory markers. Actually, some were getting better. Most of these were at least a week in to their course. And were clinically getting better, and then actually each of them blew a pupil, and that was how they were found.
Did they get surgery?
So the one in the middle did get a hemicraniectomy, and actually herniated despite the hemicraniectomy. It seemed to be kind of looked like a DIC picture, like you see sometimes with severe brain trauma. And all the other two, it was not within the goals of care.
Gotcha.
They both got EVDs placed with no significant improvement, and the families quickly transitioned to comfort care.
Yeah.
And so I think, as a lot of the questions have kind of alluded to, there are a ton of outstanding questions. Predictors of good outcome in ischemic stroke patients, I would say anecdotally, it seems that patients who have preserved other organ function and have relatively mild COVID may actually be doing better. But in general, we've seen poor outcomes. Who should get anticoagulation, how much anticoagulation, what anticoagulation, and for how long, I think, are still kind of questions up in the air. And then we've seen a rash of hemorrhagic strokes, and I wonder what the etiology is of those strokes. And unfortunately, we just haven't been able to get autopsies on these patients. But I think that will be very helpful going forward. And thank you for your time. Sorry I went over.
No, thank you, Alex. And I'm gonna see up. I have a question. Oh, no.
Alex, on your comment for your hemorrhagic stuff, it seems overall from all the research being done on COVID, this is a low-grade DIC with a prothrombotic phenotype. You're getting overt DIC overall in 2.5% of patients admitted with COVID, but in people who died, it can be up to 3/4. So if the people having COVID at the late stages and they have an overt DIC, meaning having an ISTH grade of more than 5, then anticoagulation may be more likely to lead to hemorrhage. But in the majority of the people should not do this.
So interestingly, these patients all had fairly normal fibrinogens. Now, whether it was a rapidly developing DIC and the delta of fibrinogen was the problem, and maybe even though the objective fibrinogen level was normal, maybe it's the rapidly falling fibrinogen that is the, kind of the marker of their disease. I don't know, but I think these patients would have been great to do either TEG or Rotem on, just to kind of get a better sense of what their coagulation cascade is like.
That's perfect. So again, thank you, everybody. I don't see any more questions, and any more we'll take offline. We will be emailing the people that need CMEs, and we will take care of that also offline. We very much appreciate everybody's participation. Kind of in summary, we haven't seen an epidemic of strokes in COVID-19 patients. However, these folks tend to do worse when it comes to outcomes. Dr. Ahmad and Dr. Reynolds spoke very eloquently about the management and the clinical dilemmas we have in that. Dr. Labropoulos talked specifically about how COVID affects the coagulation cascade. All in all, thank you. Obviously, thank the panelists, thank the participants, and the different organizations that signed up for it. Hopefully, we'll see you all soon in one of our upcoming webinars. Thank you.
Thank you.
Thank you.
Bye, guys. Thank you.